Thank you very much, Mustafa. So the two presentations are open for discussion. Any question from the audience, please?
Hello.
Hi.
Hi, I'm Fred Piracci, Denver, Colorado. I enjoyed the presentation very much. Thank you. So I'm a trauma surgeon, and about once a month we have to do emergent median sternotomy for penetrating cardiac injury, cardiac tamponade. So I have a practical question. What is a tip for an easy way to perform a median sternotomy emergently if we unexpectedly encounter one of these bars, either in front or behind the sternum? Thank you.
You don't.
Yes. It is very difficult, to do the median sternotomy. First, you have to remove the bar, but you need special instrument to remove the bar. That's why we advise the patient in this time too much careful about the traffic accident or skydiving or something else. That's my advice. Yes.
Yeah.
I think if you really should do an emergency case, you should have a metal cutter just to cut, even it's not sterilized, so we can get in, because removing the bar takes about 30 minutes, 40 minutes maybe. There can be a lot of reaction around the ends and so on, so I think it's better to just cut it.
I think you'd be hard-pressed to get a knife in through those bars in the first place. Kieran McManus from Belfast. I want to ask Dr. Pilgaard about the cardiac physiology. In the UK, there's going to be a ban virtually on pectus excavatum surgery. It's not going to be funded by the NHS unless we can prove that there is a physiological effect of the deformity. Now, it's hard to prove that because, as you say, these patients get older, so they get stronger and bigger and fitter. They also become more outgoing. They have a better quality of life and feeling about themselves, so they will do more exercise and have a better, they'll go from being deconditioned to being fairly well conditioned. I have trouble convincing managers of the physiological effects when you get a patient like Cody Miller, who represented the United States of America at the Rio Olympics in their 100-meter swimming relay. And he has a very severe pectus excavatum, and yet there he is performing at that level. How can I convince people that that's having a physiological effect?
I'm lucky I'm living in Denmark, and we don't have that problem in the insurance because all the hospitals are public, so we can, when the patient paid their taxes, they can be treated without...
But this is the NHS in England, this is the public.
Yeah, I think it's because how the heart is, which position it is. As I showed you, if the heart is pushed totally to the left, the patient will probably not have any symptoms. But if it's more in the middle, and you have the compression, they will have a big advantage to have a correction. I think we need more studies. We have done one, and I think you should go home and make other studies, and you should remember to do it with exercise, because when you do it at rest, when you look at the heart at rest with echo, or you measure the cardiac output and so on, it's equal. But you have to look at the patient at exercise. So we need more studies, but I think we already have some studies, but I think that the insurance companies are not so kind that they are just saying it's enough because it's cost them money. I think that's a big problem.
Thank you.
Thank you very much for the speakers. We have to move on.